Alhamdulillah.
Mau ditunggu, saya siapkan dulu.
Sumpah PG jadi kayak gini. Enggak, kata temen gue itu lem baterainya copot.
Itu aja.
Harus dibuka kalau mau diperolehin.
Oke, itu beberapa fasilitas yang ada di program studi. Fasilitas
Kenapa-napa aku.
Yuk kita dengerin penjelasan dari
Nih Mbak, nih ininya jadi bagus nih. Jadi bagus, kayaknya kan nggak bisa.
Kenalkan, saya Agustus Master Farmasi sebagai Ketua Program Studi Sarjana Farmasi UTA'45 Jakarta. Seperti kita ketahui, program studi Sarjana Farmasi merupakan program studi yang mempelajari tentang obat-obatan. Di sini kita akan belajar mengenal senyawa obat dan sintesisnya. Belajar meracik, memformulasi, dan membuat obat yang sesuai dengan standar pemerintah. Tidak hanya meracik dan memformulasi, prodi farmasi kita juga harus mengetahui bagaimana penggunaan obat-obatan tersebut secara aman dan legal. Mahasiswa kami diajar oleh orang-orang yang profesional di bidangnya. Pembelajaran di prodi sarjana farmasi dapat Jakarta dilaksanakan secara daring, offline, dan tatap muka atau online. UTA'45 Jakarta mempunyai program beasiswa untuk mahasiswa kami yang berprestasi. Untuk wadah kreativitas mahasiswa, kita mempunyai HMPS dan program UKM. Fakultas Farmasi UTA'45 Jakarta telah bekerja sama dengan universitas-universitas ternama baik di dalam maupun luar negeri. Secara rutin, program studi sarjana farmasi mengadakan event-event tingkat nasional dan internasional seperti lomba fashion event atau UTA dan seminar-seminar farmasi internasional. Jadi tunggu apa lagi? Yuk daftarkan diri kalian di UTA'45 Jakarta. Ready tomorrow, freedom today.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Good afternoon, everyone. I am Kinta Bibi Mila as MC at this event, the guest lecture today. Today's guest lecture is about diabetes mellitus type 2. The Honorable Mrs. Dr. Arwa Muhammad Amin Mustafa as speakers. The Honorable Mr. Dr. Pharmacist Sumantri MSc as Kaprodi UTA'45 Jakarta. The Honorable Mrs. Pharmacist Rabima S. Fram as Dekan of the Pharmaceutical Study Program. The Honorable Lecturers of UTA'45 Jakarta. The Honorable the participants of the lecture. Ladies and gentlemen, on this nice occasion, let me deliver the structure of the event today as follows. 1. Opening. 2. The speech from Mr. Dr. Pharmacist Sumantri MSc as the Kaprodi UTA'45 Jakarta. 3. Reading of the speaker's curriculum vitae. 4. The guest lecture, which will be delivered by Dr. Arwa Muhammad Amin Mustafa from Madina. 5. The question and answer session. 6. The prize and closing. And before we come to the main session, let us start this by praying first. Pray based on individual belief. Begins from now.
Assalamualaikum.
Waalaikumsalam, Bu. Dan next, we invite Mr. Dr. Pharmacist Sumantri, MSc, to give us first speech. To Mr. Dr. Pharmacist Sumantri, MSc, time and place are yours.
Halo, halo.
Ya,
Assalamualaikum.
Waalaikumsalam.
Bu Rabima ini saya.
Bu Rabima yang sambutan ya, Bu?
Nggak bisa saya bicara sebentar, speak sebentar. Halo.
Ya, silakan, Bu.
Oke. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.
Di mute. Oke. Thank you. Assalamualaikum. Hai Dokter Arwah. Assalamualaikum. Nice to meet you. Dokter Arwah buka mute-nya. Buka mute-nya Dokter Arwah. Sudah. Unmute Dokter Arwah ya.
Yeah, assalamualaikum. Hi, everyone.
Waalaikumsalam. Nice to meet you.
Nice to meet you, Puan Rabima, and nice to meet everyone here. I'm pleased to be with you today.
Okay. Assalamualaikum. Good afternoon to you all. First and foremost, by good grace, we have been given this opportunity to convene this afternoon. On the behalf of the Faculty of Pharmacy, UTA'45, it's my pleasure to convene to all participants a very warm welcome to our guest lecture focus on diabetes mellitus 2. This guest lecture was held because of our concern for the health science, especially diabetes mellitus 2. Also, it is linked to the COVID-19 situation because of its comorbidities. On behalf of the Faculty of Pharmaceutical Studies, I would like to take this opportunity to express our sincere appreciation for Dr. Arwah Muhammad Amin Mustafa as our speaker from the University of Taibah, Madina.
Yes, thank you very much.
Madina. I hope you all enjoy this lecture. I also wish to express my deepest appreciation to the committee. Thank you. Once again, I welcome you all. I assure that you will enjoy this event. Thank you, Dr. Arwah. Please, let's start a committee. Assalamualaikum warahmatullahi wabarakatuh. Bismillah.
Waalaikumsalam. So shall I share the screen? Can I share the screen? Because I can't. So you can hear me now? Because I'm just.
Hello.
Hello, yes, I can hear you now.
My network nih. Halo, Ainun. Let's start Ainun, please. Sorry, network. Ainun, tolong Ainun, Ibu ini nih.
Ya Bu.
Dan halo Ainun. Halo.
Iya, Bu.
Cek dulu dalamnya ya. Ada ya.
So I can start now or what?
Wait, Miss.
Okay. Thank you.
Yeah, before we continue, here we want to convey some rules that all participants comply with. First, participants mute the audio during the event, except to answer greetings and if instruction by a moderator to speak. Two, the system that asks in this question in this comment column, which will then be read out by the moderator by format, name, institusi, and question. The question must be in English. Next will be guided by a moderator to listen about the lecture and discuss more in question and answer session. It is now my pleasure to introduce the moderator,
Ya, ini baru bisa nih.
Ainun Siti
yang dikata
Aisyah, student of Pharmacy UTA'45 Jakarta. To Ainun, time and place are yours.
Tidak apa-apa, bagaimana? Saya ikut saja.
Okay. Thank you. Good afternoon, everyone. Let me introduce myself. My name is Ainun Siti Aisyah. As moderator at this event, the guest lecture today. First of all, I would like to thank to Dr. Arwa Muhammad Amin Mustafa as speaker and all participants. Thank you joining this event guest lecture. Before we listen to the speaker presentation, let me read the CV of the speaker today.
Terkunci terus ya.
Dr. Arwa Muhammad Amin Mustafa is an assistant professor of clinical pharmacy and hospital pharmacy in College of Pharmacy,
Ya, ini sudah.
Taibah University, KSA. As an academic instructor, Dr. Arwa is teaching several courses in the clinical pharmacy and hospital pharmacy disciplines.
Terima kasih ya.
She is also a certified ketogenic nutrition specialist certificate by the board for certification of nutrition specialists, or BCNS. Dr. Arwa has completed her master and PhD in clinical pharmacy from School of Pharmaceutical Sciences, University Science Malaysia, USM, and her Bachelor of Science in Pharmacy from Faculty of Pharmacy, Helwan University, Egypt. Her research interests lie in the area of personalized medicine using pharmacogenomic and pharmacometabolomic, pharmacy practice, and the therapeutic of hyperinsulinemia as associated diseases, mainly cardiometabolic diseases. Dr. Arwa has roughly 30 publications in peer-reviewed journal Science 2014. She was also awarded USM Sanggar Sanjung Award 2016 Journal Publication Award. She has participated as speaker, presenter, and judge in several conferences, meetings, and workshops in many countries. Okay, please don't forget to make this summary the material. And now I would like to invite Dr. Arwa to present her material. Dr. Arwa, please, and time is yours.
Sorry, Dr. Arwa.
Yes. Can I share? Sorry. Is there any?
Sorry, Dr. Arwa. Mr. Dr. Pharmacy Sumantri wants to. And Mr. Dr. Pharmacy Sumantri MSc, time and place are yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good afternoon, all of us. First of all, we would like to praise to Allah for His blessing, for opportunity for us to carry out webinar this afternoon. Yeah, and I would like to express on behalf of the Dean of Faculty of Pharmacy UTA'45 Jakarta to express our sincere thanks to Honorable Dr. Arwa Muhammad Amin Mustafa for your visit to UTA'45 Jakarta as guest lecturer to deliver a topic of diabetes mellitus type 2, which is, as we know, as one of the prevalent diseases in Indonesia. And also, we hopefully, and all participants, hopefully, our topic this afternoon would be very, very valuable, very important for all of us in order to prevent and to combat diabetes mellitus as one of the prevalent diseases in Indonesia. Yeah. Lastly, once again, we would like to express our sincere thanks to Dr. Arwa Muhammad Amin Mustafa for your delivery, and good luck for everybody. Thank you very much. Good afternoon. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam. Thanks to Mr.
Waalaikumsalam. Thank you very much.
Mantri. Next, Mrs. Dr. Arwa Mohammed. Time and place are yours.
So can I share the screen?
Yes, sure.
So is it clear? Yeah, you can see.
Wait, Dr. Arwa, hello.
Hello, yes.
Yes. I'm going to tell to my students first because I need all of them having focus to this topic. So I will ask the students to focus with this material because I think it's very useful for them. So I want all of you semuanya buat catatan pena dan ada hal-hal yang penting kalian catat dengan kertas ya. Karena materi ini sangat kalian butuhkan nantinya untuk nutrisi maupun tentang diabetes mellitus. Karena dengarkan baik-baik, kalau ada pertanyaan langsung ditanyakan dengan Dr. Arwa. Okay? I'm asking my students to don't be hesitate to ask any questions to you.
Yes,
after, yes, because of it's very useful for them to know about diabetic, anything about diabetic. So that's why. Okay, you can continue. Thank you very much for this presentation. Thank you.
Yeah, it will be my pleasure. It's my pleasure to answer their questions and any questions related to the topic or related to diabetes. Just excuse you that I want to stop the camera because sometimes when with the animation it freezes the animation. I will on the time of discussion. So, Bismillah ar-Rahman ar-Rahim and Salam Alaikum. First of all, I would like to thank my friend, the Vice Rector, Dr. Diana Laila, Associate Professor. And I would like to thank the Dean and her collaborating team and all the organizers and moderator of this webinar. Today, I'm pleased to share one of the very interesting topics I like in diabetes, and I feel it's very important to halt and stop the spread of diabetes globally. So today's topic, I will be talking about the low-carb diet for effective type 2 diabetes glycemic control. So, in this presentation, I will be talking first about type 2 diabetes and its association with hyperinsulinemia and insulin resistance. And then I'll be talking about what is a low-carb, healthy fat diet and why it is effective for type 2 diabetes treatment. Also, I'll be talking about the evidence on low carb diet and what's the statement of the American Diabetes Association or other guidelines on using it as a nutritional therapy for type 2 diabetes. And then I will be talking about a very important topic for us, especially as a pharmacist, which is adjusting medications on LCHF diet, because it's very important to know how to adjust the medication for the patient if they are going to follow this nutritional approach. And then I'll be talking if there is a type 2 DM patient, how can they start following the LCHF? And if a healthcare professional like us, a pharmacist or a medical doctor or nutritionist or dietitian, would like to help the patient, then how they are going to help the patient. Then I will give a summary or take-home message. So first of all, I'm just going through a brief introduction that we all know very well, that we know that insulin is the key for glucose uptake by the cells. So if that key is present and working effectively, glucose will enter the cell, and then it will be used for energy and for other processes inside the cell. And in type 1 diabetes, the pancreas fail to secrete insulin due to immune reaction or any other issue affected the beta cell. So there is a deficiency of insulin in type 1 diabetes. So by this, the glucose will accumulate in blood vessels and the patient will get hyperglycemia, and then he or she will be diagnosed with type 1 diabetes upon further diagnostic tests that confirm that it is type 1 diabetes. In type 2 diabetes, the issue is quite different. The insulin is present, and the issue is that cells fail to respond to insulin properly. So the key, which is the insulin, does not work properly with the lock, which is the receptor of the insulin. And hence the cells will not respond in a proper way, and the glucose will not be uptaked by the cells. Accordingly, this will cause an accumulation of glucose in the blood vessels and causing hyperglycemia also. Today, our talk will focus only on type 2 diabetes, and maybe in future, we can talk about type 1 diabetes. So, as we just said, in type 2 diabetes, the insulin is there, is available, but there is what we call it insulin resistance from the cells. So the insulin is not working properly, or the cells fail to respond to insulin properly. That will actually cause an accumulation of glucose, and according to this accumulation of the glucose, a message will go to the pancreas asking for more insulin, because the pancreas will sense that there is a glucose in the blood. So this means that properly we need to secrete or produce more insulin to compensate for this resistance. So what will happen? The pancreas will secrete more insulin, and this insulin will increase. Sometimes the increase in insulin will force the cells to respond to some extent to the insulin, and it will let some of the glucose to enter. And on other times, by the time more insulin resistance and more hyperinsulinemia will happen, and the glucose will accumulate in blood vessels. When the insulin increases, this will give message to the cells that there is too much of something, so the insulin resistance will increase. It will not decrease. You know, our body, when we take something in abundance, our body will start to refuse it. So the insulin resistance will actually increase. And by the time the insulin resistance will increase, the glucose will also increase, giving a message to the pancreas to secrete more insulin, and the patient will be in this dilemma. So to simplify, a patient who is suffering from type 2 diabetes, he go through a pathological process of what? First, he will suffer from insulin resistance. And then this insulin resistance will cause hyperinsulinemia. Hyperinsulinemia will cause more insulin resistance. The more insulin resistance will cause more hyperinsulinemia, and the patient will be in this vicious cycle. This cycle, when it starts, usually it starts before the diagnosis of type 2 diabetes by several years, maybe 10 years, maybe 5 years, maybe more than 10 years, maybe 15 years. Because we only diagnose the patient with type 2 diabetes when hyperglycemia reaches the criteria of type 2 diabetes diagnosis. Without reaching the criteria that were set by the guidelines, we cannot diagnose the patient with type 2 diabetes. So during the time before the diagnosis with type 2 diabetes, actually the patient is suffering with insulin resistant, and usually he don't know. We always hear that someone, he went for the hospital for a checkup or something, and he's checking for another problem, for something not related to diabetes. And suddenly, upon testing, they will discover that he's having either glucose intolerance or either he's having the type 2 diabetes. So usually it comes unexpectedly. Why this happened? Because the patient was long before suffering from insulin resistance, hyperinsulinemia vicious cycle, and he doesn't know that he's suffering from type 2 diabetes until it reached the level of hyperglycemia for the criteria of a diagnosis. So type 2 diabetes patient lives in a vicious cycle of insulin resistant and hyperinsulinemia. Studies showed that by the time the patient is diagnosed with type 2 diabetes, the functions of the beta cell loses from 30 to 60% of their function. I mean, an exhaustion will happen to the beta cells due to the over-secretion of insulin to overcome the insulin resistance. So now here's the question. What's the issue with hyperinsulinemia, and maybe why we are now concerned with hyperinsulinemia? Some studies before used to confirm that type 2 diabetes originally is because of insulin resistance, and insulin resistance developed hyperinsulinemia. But now recent research evidence is talking about that it is probably the hyperinsulinemia drove the insulin resistance. We will discuss that during this lecture today. So to understand why is hyperinsulinemia is a concern, and we have to look for it and think of it when we think for type 2 diabetes treatment. So first of all, we have to understand what's the role of insulin. We all know that insulin increases the uptake of glucose, but insulin has a lot of many other roles. Insulin is a very important hormone in our body, and we call it the anabolic hormone. We call it the anabolic effect of, it has a lot of anabolic effects. Sometimes we call it the anabolic hormone. Sometimes we call it the anti-catabolic hormone. Sometimes we call it the hunger hormone, and we will talk later why we call it the hunger hormone. So why is insulin considered an anabolic hormone? So first of all, insulin increases glucose uptake by the cells, and this glucose will be used as an energy. And then also insulin will increase glycogenesis. Glycogenesis is the formation of glycogen. And what is glycogen? It's the store of glucose in liver and muscle. Why we store glycogen? We store glycogen to use it in the time that we need energy. We need energy for activity. We need energy while we are fasting. We need energy while we are sleeping. When insulin in its lowest level. Not only that, we just said that insulin is anti-catabolic hormone, so it reduces glycogenolysis. So it keeps and maintains the store of glycogen. Okay, and it also reduces gluconeogenesis. What is gluconeogenesis? It's the process of formation of glucose from other food sources, like from protein, from amino acids, and from also fatty acids. Our body has the ability to form glucose from other sources, like amino acids, from protein, from fat, from other sources. So insulin maintains that it reduces gluconeogenesis because it maintains other stores as well, not only the store of glucose. Let's see. Insulin increases protein synthesis in the body. So it is very important for the formation of enzymes, the formation of our muscles. So it's very important hormone for our growth. And not only that, insulin increases the DNA synthesis. So it is very important for the growth. And that's why when we see patients who are suffering from type 1 diabetes, or especially child's, when they suffer from type 2 diabetes, before their treatment, you will just see that they are just in a state of catabolism because they have deficiency of insulin. They have deficiency of the hormone who is responsible for the anabolism and growth of their body. So, and this explains for us why insulin reduces gluconeogenesis, which is the formation glucose from other sources like protein and fat, because insulin would like to maintain all the stores in our body. It also reduces lipolysis. It reduces fat, and it also increases the lipogenesis. It also increases the lipogenesis and increases fat synthesis and storage. So insulin maintains that the adipose tissue is having sufficient and enough fat. And what if it is enough and it is more than enough? What if we have hyperinsulinemia? Let's see. So I'll be talking in this slide about hyperinsulinemia, but in only its relation to cardiovascular disease. However, I would like you to know that hyperinsulinemia is highly associated with many diseases. And just now, while I'm giving you this lecture, after this lecture, go to Medline or PubMed and just type hyperinsulinemia and pick any disease that you feel that you are interested to know if there is any pathological pathway of hyperinsulinemia in this disease. And just type, for example, hyperinsulinemia and any autoimmune disease, or hyperinsulinemia and, for example, Parkinson, hyperinsulinemia and Alzheimer, and you will be amazed with the research evidence discussing this point. Now, in this slide, I will just be discussing the relation, the association between hyperinsulinemia and cardiovascular disease. Why cardiovascular disease? Because hyperinsulinemia and insulin resistance are highly associated with cardiovascular disease, and cardiovascular diseases are the most cause of death among type 2 diabetes patients. So we now know very well that hyperinsulinemia causes insulin resistance, and of course, insulin resistance will increase hyperinsulinemia vicious cycle. There is a good research evidence that hyperinsulinemia is associated with inflammation, or the state that we call it chronic inflammation. Chronic inflammation is now gaining a lot of interest by researchers because it's highly associated with many diseases, not only type 2 diabetes. Also, hyperinsulinemia will cause obesity. I think now, after I discussed the anabolic effect of insulin, you can understand why it increases obesity, because it will increase the adipose tissue. The more insulin you the more insulin your pancreas will secrete, the more adipose tissue you will have. Okay, and it increases sodium and water retention. And we all know that sodium and water retention means what? Means hypertension. So hyperinsulinemia is highly associated with hypertension. Hyperinsulinemia also will increase dyslipidemia. And how it's going to increase dyslipidemia? By increasing fat synthesis. It causes lipogenesis. And that's why we have dyslipidemic diabetes, or diabetic dyslipidemia. We call it. What's the meaning of diabetic dyslipidemia? Means high triglycerides and low HDL, especially. Okay. Also, hyperinsulinemia increases atherosclerosis. And how it increases atherosclerosis? In fact, hyperinsulinemia increases platelet reactivity, and also it causes endothelial dysfunction. So the blood vessel walls will be more susceptible to form atherosclerosis. So now you can see that we have a state of what? A state that we call it metabolic syndrome. Metabolic syndrome mostly is defined that it is the state where a patient is suffering from insulin resistance, obesity, especially central obesity, and also hypertension and dyslipidemia. Mostly the patient is suffering from atherosclerosis as well. Research evidence told us that this metabolic syndrome is highly associated with what? With cardiovascular diseases, with type 2 diabetes. And usually patients who are diagnosed with type 2 diabetes, if you look retrospectively to their files or medical history, you will just see what? That this patient suffered previously from probably dyslipidemia, probably from hypertension, or probably from atherosclerosis or any other condition from this type. The combination of metabolic syndrome, insulin resistance, and chronic state of inflammation will lead to type 2 diabetes. Not only that, all will come as a package with a cardiovascular disease. So now we can understand why we used before to think. Sometimes you find the patient coming to the clinic or coming to the hospital, and he's suffering, for example, from ischemic heart disease. And you will just think the first thing, are you diabetic? Do you suffer from diabetes? And the answer will be, no, I don't suffer from diabetes. Okay, and then you will think, okay, why this patient got many complications like hypertension, like ischemic heart disease, or maybe heart attack or stroke? Why all of these happen? Okay, because this patient most probably is suffering from insulin resistance. He's suffering from hyperinsulinemia, and he may get all the complications, all the cardiovascular complications of diabetes pre his diagnosis with diabetes. Now, this is much more evidence by testing for example, the HOMA-IR, which is the index for testing insulin resistance. So is there any other risk factors that will increase the vicious cycle of insulin resistance, hyperinsulinemia? Yeah, there are some risk factors. First of all is the genetic factors. There are some genetic factors associated with with type 2 diabetes. But please note that previously the research evidence, people were very optimistic that we discovered the genetic biomarkers of type 2 diabetes, so we can predict efficiently who are going to be suffering from type 2 diabetes. But now recent evidence showed that genetic predictors are not that much efficient predictors of type 2 diabetes as we used to believe before. Why is that? Because they don't work solely. There are epigenetic factors. There are also metabolomics factors. There are also many other factors, and lifestyle can affect the effect of genetic factors. So if you think that, okay, my parents are type 2 diabetes, so most probably I will be suffering from type 2 diabetes. No, you can do a lot of things to stop that. And it doesn't mean that you should face the same fate. The second risk factor is age. of course, people, when they become older, they become much more at higher risk of developing type 2 diabetes. Stress, because stress causes a high level of secretion of high level of cortisol, and cortisol will increase insulin resistance and will also increase blood glucose in the blood. Gestational diabetes is also a risk factor. A lady who suffered from gestational diabetes at very high risk of developing type 2 diabetes. Following unhealthy lifestyle is one of the most and very important risk factors of causing type 2 diabetes, and I will be discussing this in the following slides, inshallah. There are also other factors like pollution, like taking some certain medications. It will increase blood glucose, and by the time it can cause hyperinsulinemia and then insulin resistance. So let's look first for the normal pattern of insulin secretion in our body. So the normal pattern of insulin secretion in our body, we have, look at this figure, the down figure, which is for insulin secretion in our body, which is in the blue color, and the upper figure is for glucose level, which is in red color. Let's look for the insulin secretion. We have two types of insulin secreted by the pancreas in our body. The first type is the basal level of insulin, and we call it fasting insulin or background insulin. You see, we never reach the level of zero. I mean, in normal pattern or normal person who's not suffering from any type of diabetes, we never reach the level of zero of insulin. We have a level of fasting insulin. And why it is called fasting insulin? From its name, because it's the level of insulin when we are not eating, and when we are at night, and when we are fasting. For example, in Ramadan, for example, during the day in Ramadan, our insulin is during the day in fasting level of insulin. We have another type of insulin, which is mealtime insulin. You can look, this insulin at the time of after taking the meal, breakfast, lunch, or dinner, it will increase according to the level of glucose absorbed from the meal that you are taking. So if we are taking a lot of glucose in the meal, then this insulin will be secreted in a very high level to compensate for the level of glucose and to achieve the normal glucose level. If you look to the upper figure, which is red color for the glucose level, you will notice that the glucose level, yes, it is slightly elevated after the meal, but it is not spiking as for insulin. Why is that? Because our body is maintained to achieve a normal level of blood glucose until it faces the issue of hyperglycemia or diabetes. So you will find that most of the time we are having normal blood glucose. However, this doesn't mean that insulin is in its low level. No, insulin will spike according to the level of glucose that is absorbed from the GIT. Okay, so let's think of food types and how does they affect blood glucose and insulin level. We have three main food groups, which are carbohydrates, protein, and fat. And they affect insulin level and glucose level in our body differently. So for carbohydrates, we all know that carbohydrates contains sugars. Sugars means whether sucrose, glucose, fructose, all types of sugars. And it also contains starch, and starch is just a condensed state of glucose, okay? And it also contains fibers. Fibers is very okay and healthy for us, and they actually reduce the absorption of glucose from the GIT. However, let's go for the other two, which are sugars and starch. They actually cause a lot of spiking of glucose in our blood vessels, And this will cause a very high spike in blood insulin. So carbohydrates really affects blood insulin dramatically. Let's go for protein. Protein increases blood insulin, but not by the same level as carbohydrates. And that's why we just talked when we were talking about the gluconeogenesis and that insulin reduces gluconeogenesis. Protein, after some time, after digestion of protein and using amino acids as needed for protein synthesis, some of the protein may be converted to glucose in the process of gluconeogenesis. And this will cause delayed and not dramatically high level of insulin. Let's go for the fat. Fat has the minimum effect on insulin. It's almost near to the level of fasting insulin in our body. So why it has an effect on insulin? In fact, because some very rare amount of the fat can be actually converted to glucose, but it takes very long time to be converted to glucose. So if we eat a meal high in carbs, I mean, the content of the meal mainly contains carbohydrates, it will cause hyperinsulinemia after taking the meal. And what will happen after hyperinsulinemia? It will cause insulin resistance. And what will happen from insulin resistance? It will cause hyperinsulinemia. And the more hyperinsulinemia, the more insulin resistance. And the more insulin resistance will cause hyperinsulinemia. So for example, if you are eating 3 to 5 meals per day, and the 3 to 5 meals all contains lots of amount of high carbohydrates, so you are mostly in a state of hyperinsulinemia the whole day. Okay, your pancreas is very efficient. God is great, and He created a very efficient pancreas for us. It will compensate for that the first year, the second year, the third year, long years. But after long time of insulin resistance and hyperinsulinemia, insulin resistance and hyperinsulinemia, type 2 diabetes will start to develop. So let's think of the management of type 2 diabetes generally based on the guidelines. And here I'll be talking in a brief from the American Diabetes Association guidelines, but most of the guidelines, they contain the similar approach to the management of type 2 diabetes. So we have two important wings for the management of type 2 diabetes. And you cannot work on one wing and leave the other wing. You cannot. Okay. The first approach is the non-pharmacological approach, and the other approach is the pharmacological approach. Please note this, that we cannot work with the pharmacological approach without considering the non-pharmacological approach. We have to consider the non-pharmacological approach, and we have to make the patient aware of that. Okay, so for the non-pharmacological approach, there is the nutritional therapy, which may be a low-calorie diet or low-carb diet or intermittent fasting. There is also exercise. There is also lifestyle modification, means we can ask the patient to modify their lifestyle. No need to eat 5 meals per day. No need to combine a meal and a snack, and between two snacks, there is another snack. And also there is bariatric surgery. And here for bariatric surgery, I would like to highlight something. Many patients, they think, okay, I can go for bariatric surgery, especially if they suffer from obesity. And studies showed that bariatric surgery is very effective in treating type 2 diabetes. But there is an important note. Patients think they can do bariatric surgery and they can live their life freely and back to their unhealthy lifestyle as before the surgery. In fact, no, this will not give them the proper management of their type 2 diabetes. After bariatric surgery, patient has to go back for nutritional therapy or any approach of the nutritional therapy or exercise or lifestyle modification or combining all of these approaches. and he cannot live his life as pre the surgery. So this is an important point that we have to clarify for the patient. If you would like to go to the bariatric surgery, you have to know that you will need to follow the nutritional therapy or other pharmacological approach as any other patient who did not do the bariatric surgery. For the pharmacological therapy, in brief, we have, I'm sure you know, we have lots of DM medications, DM classes. So how we use them, according to the guidelines, we use them in a stepped-based approach based on the HbA1c. And how is that? I mean, we start with one medication plus the pharmacological treatment. And then if the HbA1c is higher, then we go with 2 medications plus the non-pharmacological treatment. And then if the is much more higher, then we go for medications with the non-pharmacological treatment. So non-pharmacological treatment is a package that comes with the patient during his treatment or management of his diabetes. Based on the guidelines, the management of type 2 diabetes, there should be the metformin in every step of the step-based approach of the treatment. Metformin is the first line and should be staying with the patient along with the stepped approach of his treatment. Why is that? We'll be discussing in the next slide. But this is consistent among most of, if not all, of the guidelines globally. The Canadian, the Australian, metformin is the first line and the mainstay for every patient. So if patient is in a step that he will take 2 medications for diabetes, he will be taking metformin plus another medication. If he's in the step to take 3 medications, then he will be taking metformin plus other 2 medications. Okay. So we also should consider patient's tolerability. So because if maybe the patient is having contraindication for metformin, then this is another issue, and we have to think what other drugs that we can replace metformin during the treatment of the patient. So during the treatment or the management of type 2 diabetes, we should consider the vicious cycle of insulin resistance and hyperinsulinemia. Because if we don't consider this vicious cycle, we actually are not targeting the management of type 2 diabetes correctly. We have to consider this vicious cycle. So let's see for example, metformin. Why metformin is considered the first line for the American Diabetes Association guidelines and for other guidelines, why this drug is the first line. So look at the vicious cycle. We just said that the vicious cycle is the most important and we have to look for it and target the break of this vicious cycle. So metformin works by reducing insulin resistance, meaning increasing the sensitivity of our cells to insulin. Increasing the sensitivity of the cells to insulin means the cells will increase its uptake of glucose, and this will reduce glucose in the blood. It will also reduce the secretion of glucose by the liver. But there is very important reason why metformin is important. When metformin reduces insulin resistance, what will happen? This will break the link between insulin resistance and hyperinsulinemia. So the state of hyperinsulinemia will start to reduce gradually. A patient after taking metformin, he will start to experience a nearly normal level of insulins in the blood. Nearly normal level. So hyperinsulinemia will reduce. So this means that will break the vicious cycle also between hyperinsulinemia and insulin resistance. Patient is no longer suffering from insulin resistance and he's no longer suffering from hyperinsulinemia. Unless the patient is still following severely bad habits and unhealthy lifestyle that cannot be overcome by the metformin. There is another reason mentioned by the American Diabetes Association about the metformin and how why it is the first line. It is because it has cardioprotective effect. And I think now, after I explain the relation between hyperinsulinemia and cardiovascular disease, you can understand very well why metformin has a cardioprotective effect. Metformin will reduces the level of hyperinsulinemia, and this will definitely help as a cardioprotective for our cardiovascular system. So let's go back for the nutritional therapy, which we would like to focus more in this lecture. For nutritional therapy of type 2 diabetes, I said we have first the low calorie diet. And the low calorie diet meaning reducing our daily calorie below the balance of our calories. Based on guidelines, it's 1,500 to 2,000 calories per day for men, and 1,000 to 1,500 calories per day for women. And the second approach is intermittent fasting. What is intermittent fasting? Intermittent fasting is quite different from our Islamic approach of fasting, which we call it the dry fasting. Intermittent fasting is wet fasting, where the patient, they can stop eating or eating anything contains calories, and they can only drink water or 0-calorie drinks. They will not eat any other food for certain time of the day, certain hours of the day. For example, 16 hours of fasting and 8 hours for eating. So the eating window will be 8 hours and the fasting window will be 16 hours. It can be more than 16 hours. It can be actually even up to 20 hours, but this should be under the supervision of medical direction. So more than 16 hours will need direct supervision by healthcare professionals. But within 16 hours, it is okay. That's why we always hear about research evidence talking about if we take our dinner very early and stop eating, and then we take our breakfast quite late, then we have a good gap of hours of fasting, around 14 hours or 16 hours of fasting. That will help our body to reduce hyperinsulinemia. How is this happening? Because we are increasing the time that our body in the state of its lowest level of insulin, which is the fasting insulin. By the time this will increase the sensitivity of our body to the insulin. Also for the low, with I talk first, the low calorie, what's the meaning of low calorie? How this will affect the vicious cycle of insulin-resistant hyperinsulinemia? For low calorie, this means you are eating few amounts of food, few numbers of meals, because how you will reach this low amount of calories? You will reduce the amount of meals, you will reduce the amount of food you are eating. Reducing the amount of food, reducing the number of meals means reducing the spike of insulin at mealtime and making the insulin level near to the fasting insulin level. Let's see the third approach with the low carbohydrate, healthy fat diet, or sometimes we call it restricted carbohydrate diet or low carbohydrate, high fat. And don't get worried from the word high fat. I will discuss this high fat. What do I mean by high fat? High fat diet and nutritional ketosis and ketogenic diet. All of these names, you can find it in research evidence for the same name, which is a restriction of carbohydrate. So the low carbohydrate healthy fat diet is actually discussing also reducing insulin by reducing the amount of carbohydrates that we take per day or we take per meal. And hence what it will do, all of the three approaches will reduce the hyperinsulinemia. Hyperinsulinemia is reduced means our body will increase its sensitivity to the insulin and reducing insulin resistance. Reducing insulin resistance will reduce hyperinsulinemia. So what is low carb diet? Low carb diet is a low carbohydrate, moderate protein, and high fat. And here, while I'm talking about high fat, I'm talking about calories, not about grams of fat. And we will see why it is different between calories and grams. Low or restricted carbohydrates means the patient or the person will take around from 20 to 50 grams per day of carbohydrates from his total daily calories. This will be for around from 5 to 10% of daily calories. Also, for protein, he will be taking 1 to 2 grams per kg per day for protein. And for someone who's suffering from chronic kidney disease, he will be taking 0.8 gram per kg per day. And please note that I'm not talking here about the body weight. I'm talking about the body weight without the fat. I'm talking about the muscle weight, okay, which is mostly we use the reference weight or the ideal body weight or the reference weight, okay? So the weight we use, the reference weight or lean body mass, and here the protein will perform 20% of daily calories. And before someone get worried, oh, maybe low carb is high in protein. No, it's not high protein. The same amount of protein, we are encouraged to take this amount of protein on daily basis on any other type of diet. Because why? Because our body, on daily basis, they will need essential amino acids for our enzymes, for our biological process, for everything in our body. So to get these essential amino acids, we need to take protein on daily basis, and this is the standard amount of daily protein. So it's the same amount of protein as any other type of diet. For fat, patient will take the fat until satiation, and this here is very important. This means patients should not overconsume fat. They will add fat only to the food just to feel the satiety, to feel the satiation on their meal. And how much is the amount of fat in this case? It is from 50 to 70% of daily calories. When we will choose 50 and when we will choose 70? Okay, if the patient is suffering from dyslipidemia, or is the patient is suffering from overweight, we will ask him to take 50% of daily calorie from fat. And here I mean healthy fat, and I'll be talking about that point. Then we will ask him to take 50% of his daily calorie from fat. But if the patient is not suffering from dyslipidemia or overweight or obesity, we will ask him to take 70% of fat. Now, note something. When someone is following low carb diet, his insulin mostly in the lowest level of its insulin level, near to the fasting level. And actually, the first discovery of the low carb diet, it was called the fasting mimicking diet. Means that it's a diet that can make the level of insulin nearly to the level of fasting insulin. So under the state of fasting insulin, our body actually, it will burn fat. It will not be in the state of storing fat. In the fasting state, that's why some people would say, okay, after sleeping at night, when I weighted myself in the morning, I found that I got reduced weight. Yeah, you got reduced weight because you were in the fasting state. Your insulin was in the lowest level, in the fasting insulin level, and then that induced fat burning. Okay, so our body will be in the state of fat burning. So fat here is not a matter of worry, and there is other reasons also. This should not be a matter of worry. Why? Because insulin is the hormone of hunger. What's the meaning of hormone of hunger? If insulin is the hormone, if you are taking a meal and your insulin is very spiked, this means that you will feel hungry to eat more. And that's why people, when they eat high carb meal, you'll just feel after 1 or 2 hours, okay, I feel hungry, I need to eat some snack to get some power. Okay, after this snack, if the snack is high carb, then after 1 or 2 hours, I feel hungry, I want to eat more. However, if low carb diet, it's a very minimum amount of fat he will be taking to feel full when he's taking his meal. Why? Because insulin is very low, so he will not feel hungry. He will eat the meal and he may spend hours and hours without eating another meal. So I just talked about food calories. So look at that. The carbohydrates provide 4 calories per gram. So 1 gram of carbohydrates will provide your body with 4 calories. Protein, 1 gram of protein will also provide 4 calories to our body. But look at the fat. It will provide 9 calories for 1 gram. And that explains why we said 50 to 70%. 50 to 70%, 50 to 70% means what? Calories, not means grams. So you are not going to eat, for example, you will open a jar of ghee or butter and you start to eat on a low carb diet. You will not be able to do that actually if you are following a low carb diet. Very few amount of fat, healthy fat during cooking or something that will be sufficient for the body to feel and for you to feel full after taking the meal, because it provides 9 calories per 1 gram only of fat. So what are the carbohydrates that are allowed on low carb diet? The carbohydrates, we get it from the non-starchy vegetables. Those vegetables are high in fibers, and mostly we focus on the leafy vegetables, the greeny vegetables we call. And also we can get also carbohydrates from fruits which are low in glycemic index and low in glycemic load. What do we mean by glycemic index and glycemic load? Glycemic index measures how fast the food will increase the blood glucose after consuming it or after eating it. So it should be low in glycemic index, means a fruit that will not increase the blood glucose very fast after consuming it. And glycemic load, which means the content of the carbohydrates in the fruit. So it should be very low also. This is very easy to find on the internet. You just Google low glycemic index fruits, low glycemic index vegetables, and you can find low glycemic load food and vegetables. So some examples are like strawberries, blueberries, avocados, and there are a lot of other examples. Also, we get some carbohydrates and healthy carbohydrates, we call it, from nuts and seeds. And they are very healthy because they provide us with omega-3 fat, and they a type of healthy fat. They also provide us with a lot of fibers, and there is a lot of research evidence that nuts and seeds are very beneficial for type 2 diabetes patient and for our microbiota in the GIT and our health. All simple and starchy carbs are not allowed on low carb high fat. Sugary drinks are not allowed. Grain breads are not allowed. Starchy vegetables or like potato or these things are not allowed on the diet. For protein sources, we can get it from the protein sources that we all know: eggs, dairy products. But dairy products, it should be dairy products that contains less carbs. But most of the dairy products are okay. And we also get from fish, we get from chicken, we get from non-processed meat. There's an important point on low carb diet that it should follow pure and raw food. I mean, everything which is processed are not allowed on the low carb diet. So what about the fat, which is the concern of everyone when they hear low carb, high fat diet? We explained that high fat means high calorie because fat is giving a lot of calorie compared to carb and protein. But what's the source of healthy fat? Fat rich in omega-3, especially like olive oil, fish oil, especially fatty fish, nuts and seeds are very important, and we should avoid trans fat or processed oils. And here's a very important thing. Processed oils means every oil that had been processed, even if it was originally a good type of oil. Sometimes there are very good types of oils that we can use if they are naturally pressed and organic and so on. when they are manufactured on a manufacturing scale, big scale, sometimes they use hydrogen to increase their shelf life and saturate them with hydrogen. So any processed oil are not recommended for patients using low carb diet as a nutritional therapy. And there is a lot of evidence talking about how processed oils increases insulin resistance. Animal fat are allowed on a low carb diet. And why they are allowed? This is for several reasons. The first reason is you don't need to worry of lipogenesis if your insulin is very low. Okay, so if your insulin is very low due to the following low carb diet and you don't have spike of insulin, you don't need to worry of fat synthesis. You are in a state of fat burning and not fat synthesis. I will show this when I will talk about the evidence on low carb diet. Another thing now, the research evidence are coming more and more indicating that animal fat, if they are pure and their state of pureness are not processed, there is no issue with them. So now look at the varieties of food that patient can enjoy on a low carb diet, because some patients, they would think, okay, if I will follow low carb diet, I'm going to lose a lot of food that I can eat. No, actually, they can enjoy a lot of healthy and raw and pure food on a low carb diet. The thing is, they have to adopt new way of changing their kitchen, their way of cooking, and also adapting new recipes of food to make food. And there is a lot of recipes available online in different languages. So these are the foods that are not allowed on a low carb diet. Starchy food, juices, and of course, sugary food and sugary drinks. So here, look for this example. Let's see to what extent this is really effective or not effective. On the left side of this slide, you will find a low carb meal. And on the right side, you will find the high carb meal. On the left side, the low carb meal, if you just try to calculate the amount of carbohydrates, grams of carbohydrates in this meal on any app, you can just try this after this presentation and you will see how is the amount. And for the high carb meal as well. Of course, if I will ask you which meal would you recommend for a type 2 diabetes, you will definitely think, oh, the right side meal looks junk meal, and it's better for the patient to take the low carb meal. But let's go deeply in each meal. The low carb meal, this meal contains less than 10 grams of carbohydrates, and for most of these 10 grams are fibers, are not sugars. For example, salmon fish here contains 0 carbohydrates, 0 carbohydrates. It's only few 2-4 grams from the vegetables and tomato. And if you look to the high carb meal, it contains more than 150 grams of carbohydrates. And I tried it on several apps, and I found that in some apps, it reached 200 grams of carbohydrates. Look at the difference between these two meals. Look at the difference in the amount of carbohydrates. But if I ask you, what's the reason that this high carb meal is containing that much amount of carbohydrates? The first thing you would think, oh, it contains a juicy drink. Yes, juice or drink, yeah, it may be one of the main causes that it has a lot of carbohydrates, but it's not the only cause. This meal contains a lot of starch. Starch is sugar. Many type 2 diabetes patients and many patients, they don't know that starch will quickly be digested to sugar, and it will raise their blood glucose. You can meet one type 2 diabetes patient, and he will tell you, okay, I'm drinking my tea without any sugar. I'm drinking my drinks without any sugar. However, they are eating wheat bread They are eating rice. They are eating high carb food. Here, this meal contains potato, and potatoes contain starch and high amount of starch that will break down to sugar. So low carb meal will have lower spike in blood glucose and insulin. Let's see that. So what will happen if someone is going to eat high carb meal and someone will eat low carb meal? If someone will eat high carb meal, the meal will be mix of carbohydrates, protein, and fat. So it will not be exactly the same spike as the carbohydrates, but it will be something like a combination of the three groups. So here the carbohydrates rich meal, which is in red color, and the low carb meal, which is in blue color. And see the difference in the elevation of blood glucose and accordingly the elevation of insulin. So if the patient eats high carb meal, what will happen? This will cause an increase in insulin, hyperinsulinemia post the meal, and this hyperinsulinemia post the meal will increase insulin resistance, and insulin resistance will increase hyperinsulinemia, and you will be in the vicious cycle. And this happens actually before the diagnosis of diabetes. So after the diagnosis, it's much more worse, in fact. So what if the patient will eat low carb meal? There will not be hyperinsulinemia, very low amount of insulin. So this will reduce the insulin, and accordingly, this will reduce insulin resistance. What will happen to this vicious cycle? It will be broken, and blood glucose will reduce, and insulin resistance will be treated by this nutritional approach. So low carb meal will have lower spike in blood glucose and insulin. Now, many patients, they would say, okay, I don't think that I will be able to look after eat food and look to the apps and check for the amount of carbohydrates and check how many grams I need to eat, what type of eat I want to eat. I'm confused, and so on. So here there is, here I'm showing you the infographics that were created by Dr. David Amen. Dr. David Amen, he's a famous British medical doctor who treats his patients with low carb diet, and he's a famous researcher in the field of management of diabetes with the approach of low carb diet. He developed an infographics with the amounts of sugar contained in starchy food or in foods that people really sometimes they don't think that they contain high amounts of carbohydrates. How he developed these infographics? Actually, 1 teaspoonful of sugar usually contains 4 grams of glucose or carbohydrates, okay? So according to this, he used his calculations using the glycemic index and glycemic load to calculate the amount of teaspoons of sugars in each serving of food. And here he developed around 8 infographics. These infographics were translated into several languages, including Bahasa Malaysia, and maybe I can collaborate with Dr. Diana to make it also available in their website with the Indonesian language. Now, see, look in this infograph, he showed that broccoli, for example, it contains nothing from a teaspoonful of sugar. Almost nothing of teaspoonful. And he also mentioned some examples that can help the patient to choose their food. Some of his patients used to stick these infographics in the kitchen, so it can help them to select food wisely. So these sugar infographics are available can be downloadable from their website. Now it's available in 14 languages. And there are other languages as well on the way from the Public Health Collaboration website. So the main important point from these infographics, that starch, to make the patient aware, the starch is sugar. So now people would say, okay, if we follow low carb diet, we will lose a lot of things. We will lose taking desserts. We will lose many things in our that we used to enjoy before in food and those things. So no, it's not like that. People need to know more about low carb diet recipes and how to make low carb meals and low carb food and desserts. Now I picked two examples of low carb dessert and high carb dessert, and to compare them, and we will see how much carbs and calories are in each of them, and we can see also how much fat. So on the left side is the low carb dessert, and on the right side is the high carb dessert. Let's take the high carb dessert. This high carb dessert, what does it contain? It contains rice milk. Rice milk is a type of dessert which contains rice with milk and sugar. It's common in the Arabic kitchen, and it contains also fruits, different types of fruits. Here I can see apple and grapes, I think pineapple, I think it's a cocktail of fruits. And also it contains kunafa. Kunafa is an Arabic dessert, and also basbousa, another type of Arabic dessert. And then it contains more fruits, and then cream, and then ice cream, and then brown chocolate, and then white chocolate sauce, and honey, and some nuts. Do you really think with me, how much calories it contains and how much carbs it contains? Total calories of this dessert is 1,725 calories, and total amount of carb more than 240 grams. It contains sugars, 180 grams, of them few amount of fibers. And for your information, if fibers are very low, their effect on reducing the absorption of glucose, if they are very low compared to the sugars, their effect on reducing glucose absorption is minimum, not as we expect from the fibers. Okay, let's see the low carb diet. But before we go here, if you divided 240 grams on 4 grams for each teaspoon of sugar, you will find that this dessert contains 60 teaspoonful of table sugar. And let me ask you a question. Do you go to the restaurant to eat only the dessert and you don't eat any other food? Or you take drink with it and you also take other food with it? Let's go for the low carb dessert. This low carb dessert contains what? It contains almond flour, I think 2 tablespoons of almond flour, 1 egg, butter, 1 cube of butter, sugar-free sweetener, and you can even exclude it, vanilla extract, coconut flour, and you can even use coconut flour instead of almond flour, unsweetened cacao powder, and baking powder. How many calories in this dessert? It contains 240 calories. Can you compare both? It is totally different. Total carbohydrates is 8.5 grams. And how much sugar of that? 4 grams of sugar. How much fiber? 4.5. It's almost more than 50% of the carbohydrates are fibers, which means they will reduce the absorption of the 4 grams. See how much it's beneficial? Not only that, if you look to the high carb dessert, it contains a lot of fat. That's why when sometimes some patients they feel somehow concerned if they follow low carb diet, they might consume high fat. I usually tell the patients, if you are able to reach the fat level that you used to consume before following low carb diet, that will be very high level. That will be very high level, and you will not able to reach it. Why they will not be able? Because when we consume high carb meal, our insulin is very high, our hunger hormone is very high, and we are in a state of storing fat. So we consume more food. We may be consuming more fat. And when we will follow low carb diet, we actually will not going to consume that much fat that we used to consume on a high carb diet. And we will feel full very early. So low carb dessert will have lower spike in blood glucose and insulin. So when we eat low carb dessert or low carb meal, it will reduce hyperinsulinemia. It will reduce insulin resistance. It will break the vicious cycle. So let's talk about fat burning on a low carb diet. One of the risk factors of type 2 diabetes is obesity, and it's due to hyperinsulinemia and insulin resistance. And the more the person become obese and having more fat, the more they become more insulin resistant. So low carb diet will reduce insulin compared to high carb diet. When insulin is at its lowest level, lipolysis will increase. Means what? Means burning fat. So fatty acid will have beta oxidation in the liver. After beta oxidation, it will form acetyl-CoA. Acetyl-CoA will form ketone bodies. And ketone bodies such as what? Beta hydroxybutyrate, acetoacetate, and acetone. And before you get worried and jump and say, oh, these are ketone bodies, and we are worried the patient will get ketoacidosis or diabetic ketoacidosis, I assure you this will not happen, especially in type 2 diabetes. Why? Because this process is not going on without stop. There is a feedback mechanism. When we form ketone bodies here are used by our body as an energy source, same as glucose. And now there are a lot of research talking about their beneficial effect in treating heart failure, Alzheimer, Parkinson, and epilepsy and other diseases. And after they reach a level within the normal level, but slightly high, near to the borders of normal level, they will send the feedback mechanism and insulin level will increase to stop the process of high lipolysis. So our body will be in harmony of having a lipolysis, but there is a feedback mechanism. We stop doing lipolysis. We have enough ketone bodies for energy, and we burn sufficient fat today to stop for today. So low carb diet is very effective in fat burning and reducing weight, which is a risk factor for patients having type 2 diabetes. And many of the patients, they are suffering actually from high weight. Now, since I talked about ketone bodies, I need to highlight the difference between two terms that sometimes they are, there's a misconception between them or they are mixed. The first term is DKA or diabetic ketoacidosis, and the other term is or physiological ketosis. DKA, we all know, is a serious emergency condition, mostly happen in type 1 diabetes, and it's very rarely happening in type 2 diabetes because type 2 diabetes, they don't reach the zero level of insulin or near the zero level of insulin. DKA results from insulin deficiency or illnesses. And during the DKA, the blood glucose will be much more than 250 milligram per deciliter. Ketone levels will be much more than 10 millimole per liter. I have seen some cases where the ketone levels reach on DKA 25 millimole per liter. Let's go for nutritional or physiological ketosis. This is a healthy physiological state indicating fat burning. It occurs with low carb diet or prolonged fasting. And let me remind you, when we fast in Ramadan, for example, we always know the breath, the odor of the breath. This is the odor of ketones. It's a natural natural physiological process happen in our body when insulin is in the low level. So lipolysis is going on. So blood glucose during the nutritional or physiological ketosis are in normal and ketone levels from 1 to 5 millimole per liter. Now I will go to the second part of my lecture, which is the literature evidence on low carb diet. I'll start with the evidence from the American Diabetes Association, and here I'm in front of you is the statement from the ADE Standards of Care Guidelines to 2020. So what's their statement? In Section 5, facilitating behavior change and well-being to improve health outcomes, the standards of medical care in diabetes 2020, they mentioned reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia and may be applied in a variety of eating patterns that meet individual needs and preferences. For individuals with type 2 diabetes not meeting glycemic targets or for whom reducing glucose lowering drugs is a priority, reducing overall carbohydrate intake with a low or very low carbohydrate eating pattern is viable option. Not only that, this is Mrs. Tracy D. Brown. She's the CEO of American Diabetes Association, and she's actually a type 2 diabetes patient. She mentioned in one of the interviews that she's following a low carb diet to manage and control her diabetes. What she said in the interview, here's what I do, and it is pretty simple. Elevated blood sugars happen when you have sugars in your body and you don't have insulin to manage the sugars. She means here by don't have insulin, I mean the exhaustion of beta cell functions after the diagnosis of, with type 2 diabetes due to hyperinsulinemia for long use. And you don't have insulin to manage the sugars in your body, carbohydrate turn into sugar. So I just try to get, I just try to get people to be aware of how many carbohydrates you are actually putting in your body. Carbohydrates come in many shapes and forms. Bread is carbohydrate, pasta is a carbohydrate. Actually, fruits, some people go fruit, but some fruits are high in carbohydrates. So as someone living with diabetes, you have to be mindful of sugars and carbohydrates. So here I'm showing you one research evidence on low carb diet. And this is a study conducted in Verta Health Clinic in San Francisco and supervised by Dr. Sarah Halberg, who is famous for her TED talk in 2015 when she talked about the low carb diet and the important type 2 diabetes patient. You can search on YouTube for her talk, and it's a very nice talk. So in their study, after 1 year of following patients, they found that HbA1c lowered by 17% on a low carb diet. They also found that fasting glucose lowered by 20%. They also found that fasting insulin lowered by 43%. They also found that HOMA-IR, the index for indicating insulin resistance, lowered by 55%. Triglycerides lowered by 24%. And here comes the answer for some patients who are worried from eating fat on low carb diet. We are not asking you to eat a lot of fat because you will not be able to eat a lot of fat on a low carb diet. And patient will ask, if I eat fat, I'm going to lose fat? Yeah, if you eat fat and you reduce your carbohydrates, you will lose fat and your dyslipidemia will be treated and cured. It also increased the HDL cholesterol by 18%. So this diagram shows that the changes on HbA1c over a course of 1 year for continuous care intervention. I mean, and here it means continuous care intervention are patients who were following the low carb diet in this study. Usual care were the patients who were following the usual diet in this study. See the difference between a baseline and 1 year for the HbA1c, and see the difference here. It's almost no difference for the usual care, and even sometimes for some groups, after 1 year, the HbA1c increased on usual care. Usual care means a normal advice of diet, and it does not contain any advice on restricting carbohydrates. So it showed in the study that there was a decline in the weight around 13.8 kg and overall. So this is a very important slide for us, especially for us as a pharmacist. This slide, they showed in this diagram what was the elimination of medications on low carb diet. Look at the left side diagram. This left side diagram is for patients who were following the low carb diet. Look at the dark blue color, which is a drug where the percentage of drug eliminated, or the percentage of patients eliminated the drug, and the light blue color is percentage of decreased dose or dose reduction. Look at this. 100% of patients who were having or taking sulfonylurea, they eliminated sulfonylurea on the low carb diet. So if they were taking metformin and any other other drug from the sulfonylurea class, they were 100% free from the sulfonylurea drug. So they reduced this medication. Look to the second drug, the insulin. Insulin here, see 47.6% of the patients who were taking insulin before following the low carb diet, they eliminated insulin. And here's the very interesting thing. We used to believe, some patients, they used to believe that if they will start to take insulin on, if they are type 2 diabetes and they will start to take insulin, they will be on insulin forever. No, they will not be for insulin forever. They actually can eliminate insulin or reduce the dose. Look at this. This is 46% decrease the dose of insulin. So in total, more than 90% of those who are taking insulin either eliminated using insulin or reduced the dose of insulin. Look at SGLT2 inhibitors. How many percent? 91% eliminated the drug. Look at the glitazones or thiazolidinediones. 80% eliminated the drug. DBB4, 54% eliminated the drug. GLP-1, incretins, 28% eliminated the drug. Metformin, 18% eliminated the drug. However, metformin, it does not cause any, for example, hypoglycemia on the low carb diet, and it's okay for the patient to be on metformin while he's following a low carb diet. Let's go for the usual care after one year. See how many eliminated sulfonylurea compared to the low carb diet. And here's a 16%. Look for the other drugs as well. It's really low percentage of patients eliminated or reduce the dose. And in fact, they either were with no change in the dose, or they got increase in the dose, like those with insulin. See here, the amount is 30% of the patients who were using insulin but not following low carb diet increased the dose of insulin. However, here it's almost nothing. I mean, it's very, very low percent. I think it's 4%. After 2 years, they continued to follow the same patient, and what they found the same evidence. HbA1c, fasting glucose, fasting insulin, HOMA-IR, triglyceride, all reduced on the low carb diet. HDL cholesterol increased on the low carb diet. Not only that, they also found after 2 years that kidney function improved, which is very, very interesting findings in this study, because kidney function will improve with the improvement of glycemia. So patients, if they improve their glycemic control, they will have their kidney function being better. So they are improving their glycemia with less medication than before. So accordingly, the complications of diabetes are improved. Also, their liver function improved. One interesting thing is the visceral fat content reduced, which means that they reduced their metabolic syndrome cause of of diabetes. Blood pressure improved. Why blood pressure improved? I explained before that hyperinsulinemia will cause sodium and water retention and will cause hypertension. Reduced dependence on medications. Patients mostly are no longer dependent on medication, and on low carb diet, many of type 2 diabetes, especially if they follow that in the early stage of their disease, they will be free from medication if they follow this as a lifestyle. Here is another study by Dr. David Unwin. This study the objective was to check for the hypertension and hypertension medications on a low carb diet for patients with type 2 diabetes who are having type 2 diabetes and also hypertension. So what they found in this study, they found significant and substantial reduction in blood pressure. And also there was a mean reduction in weight of 9.5 kilograms, marked improvement in lipid profile, and also 20% reduction in antihypertensive medication. What an interesting approach, that the patient will reduce his medications for diabetes, he will reduce his medication for also hypertension. The two most commonly prescribed drugs were printopril and amlodipine. This effect was sustained for 2 years, and there was a very nice effect also on CV risk factors, not only blood pressure. And you can find that by searching for this study, and it's very interesting study. Also, there are other studies discussing the effect of low carb diet on the cardiovascular risk factors. So I have mentioned in this lecture about the animal fat, and I said pure or raw fat, usually whether they are plant or from animal, are mostly safe. Now, yeah, we are coming from a previous era that most of the fat are evil, but this is not really simple as such with the recent research evidence. The recent research evidence showed that fat, if they are pure and in their raw state, are different from if they are processed. And pure state or raw fat might be healthy and helpful to our body. Look at this review. This review was published in October 2020. This is very recent, and it was published in the Journal of the American College of Cardiology. And you know, it's a very important and with high repetition journal in the field of cardiology, and it's a state-of-the-art review. So what they mentioned, they said that saturated fat and health, a reassessment and proposal for food-based recommendations, and they reviewed all studies, including randomized clinical trials and meta-analysis on the effect of fat on our health, and especially the natural fat. So what they concluded, they said most recent meta-analysis of randomized trials and observational studies found no beneficial effect of reducing saturated fatty acids, and here they mean the natural intake, on cardiovascular disease and total mortality, and instead found protective effects against stroke. Although saturated fatty acids increase low density lipoprotein LDL cholesterol in most individuals, this is not due to increasing levels of small dense LDL particles, but rather larger LDL particles. And we know the difference, that large particles are not harmful for us. Large LDL particles are not harmful for us like the small and dense particles, which are much less strongly related to cardiovascular risk. Different saturated fatty acids have different biological effects, which are further modified by the food matrix and carbohydrate content of the diet. Here is very important. Why by the carbohydrate content of the diet? Because the carbohydrate content of the diet will change the level of insulin, will change the process of lipogenesis. Whether it will happen or will not, it will increase or decrease. It will increase with the increase of insulin, and it will decrease with the decrease of insulin. So we cannot lump saturated fat in one word and say, okay, you avoid saturated fat. It's better to tell the patient, avoid carbohydrates rather than to tell them saturated fat. We have to tell them, avoid trans fat or avoid processed fat. Several foods relatively rich in saturated fats, such as whole fat dairy, dark chocolate, and unprocessed meat, are not associated with increased cardiovascular risk or diabetes risk. Let me give you an example. Coconut oil is also saturated fat, but it's very healthy. It's very useful for and healthy for our body. So here, this is a summary in the study in the review. They said the previous advice was restricted saturated fat intake to reduce the of cardiovascular. Then studies showed that these natural saturated fat, their effect differ with the carbohydrate content of the meal and also the type of fatty acids in the meal. So now there should be a new recommendation should emphasize food-based strategies that translate for the public into understandable, consistent, and robust recommendations for healthy dietary pattern. And we expect that will be a dietary guidelines by the end of 2020 or early 2021 for the whole population. It's not only the diabetes patient, that will contain some more details regarding fat and explaining the new evidence on that. So here is a very important point. As you can see in this in the study I showed you, that the medications should be carefully managed on low carb diet. From the first day, the patient is going to follow the low carb diet. So pharmacological treatment for type 2 diabetes patient on low carb diet should be adjusted to prevent hypoglycemia in patients using fixed doses of insulin and insulin secretagogues. Why is that? To avoid hypoglycemia. Insulin secretagogues, hypoglycemic drugs should be reduced or discontinued. Bear in mind, these should be reduced from the first day, or at least the patient will be followed for a couple of days and with the gradual reduction of the doses. This is a very important point because many patients, they hear, for example, other patients are taking, oh, I followed low carb diet, I'm no longer, my glycemia was okay. So the patient will start by themselves following the low carb diet without referring to the healthcare professionals or medical doctors. And then what will happen? They will suffer from hypoglycemia from the first day. The first meal, not the first day. Insulin dosing should follow basal bolus approach, not pre-mixed insulin with no fixed doses. I mean that patients who are following insulin with fixed doses, like 6 units for breakfast, 8 units for lunch, cannot follow a low carb diet unless they are taught how to do carb counting and adjust their doses based on the carbohydrates in the meal, or their doses should be reduced. If it happened, inshallah, in the future, I give a lecture on type 1, I will discuss how to adjust insulin doses based on the carbs in the meal. Meals carb counting and insulin to carb ratio calculation should be applied. Adjustments should be individually and based on blood glucose record. Also, combination of SGLT2 inhibitor drugs with low carb diet is contraindicated. Why is that? Because they may increase the chances of euglycemic ketoacidosis. Why is that? Because SGLT2 inhibitor, they have a side effect of euglycemic ketoacidosis. So if they were combined with low carb diet, we are worried that the small amount of ketone bodies that will raise on a low carb diet will add to this side effect for insusceptible people. Antihypertensive medications may require adjustment on a low carb diet. So doses may require reduction, or patient may require elimination of antihypertensive medication. So there might be a deprescribing of medication of those prescription, reduction or adjustment. So now we come to the question that many patients will ask. I am a type 2 diabetes. I find myself very interested in following low carb diet. What I should do to follow low carb? So the first thing we have to tell the patient and make them aware, they have to find a trained healthcare professional. They have to find a trained healthcare professional on a low carb diet who knows how to adjust medications on a low carb diet, or else they can face hypoglycemia or side effects. So they have to find a medical doctor, diabetes educator, health coach, dietitian, nutritionist, pharmacist, or a nurse who are trained on following a patient on a low carb diet. So the second thing, we ask the patient to get sufficient education before following the diet. It's not like today I'm going to follow the low carb diet, so I will start from now. No, they have to get sufficient education, food options. What are the food options available in my country? What are the food options that I like, that I don't like from the allowed and not allowed food. They have also to know food carbohydrate percentage. They can use a mobile application or the sugar infographics that I talked about them. They also should learn how to adjust their meals plan, because it is different kitchen, because they will change things in their kitchen. Low carb diet, they should find low carb diet supporting resources, and this is the healthcare professionals will help the patient, and they will give them resources in their languages, like online resources, mobile apps, and books. Also, the patient should get their family support, because they need someone to help them for cooking at home, or maybe they will cook for themselves, and maybe because they will maybe change their way of eat. So some families, they choose, okay, this way is very healthy, so we all are going to follow the same way of eating, same as our parents, our father, or like that. So this will be very helpful and supportive for the patient. Also, the patient should make sure to follow up himself by recording the blood glucose and blood pressure measurement for his next visit to the doctor, and they should show them to the doctor so they can adjust for them their medication, their doses, and because they were in a process of de-prescribing and reduction of doses for several months after following the diet. So what about healthcare professionals? I always get this question that if I am a healthcare professional, I would like to help patients to follow the low carb diet, and I'd like to learn more about this nutritional approach and adjusting medications. So the first thing I would say is to get the knowledge and training. And this could be through CME training courses, conferences. Today's lecture is like scratching that maybe can help others to search for more information. Also, they can get to be certified in this, like low carb diet certified courses and board certification, like the certified ketogenic nutritionist specialist, which is offered by the American Nutrition Association. For healthcare professionals, they will take the courses, and they will take an examination, board examination, and that. So other resources, also online resources, books are available, and I will mention some resources at the end of this lecture, inshallah. So comprehensive review, what you should do also for the patient, they should do comprehensive review of the patient's profile, especially the type 2 diabetes patients. They are mostly on polypharmacy medications, and they will be taking medication for diabetes, medication for example, for cardiovascular disease. Maybe they have previous event of ischemic heart disease, stroke, or whatever. So they may be taking other medications for peripheral neuropathy, for kidney disease. So these need comprehensive review of the patient's profile. Focus on patient education. They should educate the patient either individually or groups. And now globally, a lot of hospitals are offering groups education to patients. They are offering webinars to patients in their own language. They can do also follow-up. They will do follow-up for the patient and frequent visits in the early stage of low-carb diet. And they can also do online consultation. A lot of hospitals are providing digital therapeutics for patients who would like to follow low-carb diet. So healthcare professionals, whether a resident pharmacist or the medical doctor, the dietitians, they can follow their blood glucose on the app, and they can actually give them advice and tell them, okay, today you have to stop this medication because your blood glucose are going to be in a high bow on the next day. So these are some resources, and here I'd like to tell a few about these resources. For example, the website of Diabetes Core UK is a very, very useful website. It contains a lot of information and studies about the low-carb diet, and also very helpful for patients of type 1 and type 2. And it contains a lot of recipes containing very detailed information about the amount of carbs, fats, and so on. There is the Low Carb Down Under website, which is an Australian website, and this site is very, very, very nice website. Contains a lot of studies, updated meta-analysis, updated randomized clinical trials, and all of the research evidence. It contains many, many, many lectures that can be very helpful, that you can get a lot of information. And what's interesting also about Low Carb Down Under, they have a list, an updated list of healthcare professionals who are trained on following the patients on low carb diet. So patients in Australia, they can actually go to that list and they find someone in their area to help them if they want to follow the diet. Also, the website of Public Health Collaboration, where you can download the infographics, and they have an updated resources of research evidence, and also a lot of lectures and information that you can get, some guidelines on following the low carb diet that can help also healthcare professionals. There is the website of Verta Health, where I discussed one of their studies. They have an update of their study, and they have an update of other studies, a lot of lectures that can help in getting more information and increased knowledge in this. So last thing I would say, the take-home message, LCHF is effective and safe type 2 diabetes nutritional therapy. Medications adjustment on LCHF is crucial to prevent hypoglycemia and drug side effects. And please bear in mind this information. This is very, very important, and because we have to make patients aware of that, because it's widespreading now. A lot of patients, they know that low carb is effective, but they don't know how it interacts with their medications. Healthcare professionals should obtain training before helping the patient. Patients' awareness on LCHF should be improved through awareness activities. So thank you very much, and I'm sorry, I feel it was a very long lecture, but I hope you benefited from it. So is there questions in the chat?
Okay, thank you, Dr. Arwa. Thank you, Dr. Arwa, for interesting material. That was the presentation by Dr. Arwa. And now we're going to the next is a Q&A session. There are already 3 questions. Now I will read the first question from...
So you will tell me the questions from the chat, because I cannot really get the starting of the questions, or sorry, or you will be reading the questions, or so.
I think better they ask you directly. I think each student can ask directly. The committee can unmute the speaker so they can talk to you directly. I think it's much more better, I think.
Oh, okay.
Isn't it? Mary mau tanya ya tadi ya? Mary bisa tanya, Mary. So for each student who wants to ask Dr. Arwa, please open the video so you can see, and it's good for you to see and talk directly to Dr. Arwa. Okay, silakan. I think Mary is the first. Silakan, Ainun.
Okay. Tanya Mary tadi.
Yes, Miss, I already read the question on the column, in the column. Doctor?
Yes, yes.
I have 3 questions. I already read down on the column, on the comment column.
Comment, or you mean
yes.
chat column? I've tried to reach them. Can you just tell me the question?
Yes,
Because
okay. The first question is, can type 2 diabetes be prevented?
Be prevented?
Yes.
Yes,
and
it can.
second, yep.
Definitely.
Second, is
You
there
want
a
me to
cure?
answer? Yeah, okay.
Is there a cure for type 2 diabetes mellitus? And the last.
This is the second question. Yeah, tell me the last question.
And the last, are there alternative treatments for that type?
Type 2 diabetes,
Thank
you mean?
you. Only that 3 questions.
Yeah, I mean, the third question, I just need some clarification on the third question. You said the first question, can type 2 diabetes be prevented? And the second question, is there a cure for type 2? And the third question, you just said, is there an alternative? What?
Alternative treatment.
Alternative treatment. What you mean? What by alternative treatment? Herbal treatment?
Yeah, I think herbal. They mean is herbal.
Yes.
Yeah, okay. So let's go first for your first question.
Thank you, doctor.
Most welcome. Can type 2 diabetes be prevented? Yes, surely. And actually, this is, you know, the time of the lecture is very limited. You can just evidence that type 2 diabetes was that patients with pre-diabetes were reversed to normal using the low-carb diet. So following a healthy lifestyle or a lifestyle that maintain your insulin, mostly not in the very high level, will prevent the occurrence of type 2 diabetes. Also, low-carb diet, there is a lot of evidence that it has been used to cure metabolic syndrome, which is one of the main risk factors of type 2 diabetes. For your second question, you said, is there a cure for type 2 diabetes? In some research evidence, they call the low-carb diet, it can lead to remission from diabetes. And they mean by remission that the patient be free of all type 2 medication, type 2 diabetes medications, and living without any medications, and he's having normal glycemia. Normal glycemia, I mean that he's having a fasting blood glucose between 80 and 100 milligram per deciliter, and also having normal HbA1c, HbA1c below 5.7%. So to some extent, you can call it a cureness for diabetes because the patient, if they follow this lifestyle, they can live very normally. They can live even healthier than someone who's not diagnosed with type 2 diabetes, but he's following unhealthy lifestyle and probably suffering from insulin resistance and hyperinsulinemia. So the third question, is there an alternative treatment? So there are a lot of herbal drugs that were investigated for their effect on insulin resistance and for their effect on reducing hyperinsulinemia or increasing the sensitivity to insulin, or increasing the uptake of insulin, the uptake of glucose by the cells. And there's evidence on that. But even if they were used, or if they will be used, but they will not have the same effect as the effectiveness of using nutritional therapy. You see, look at that. If the patient is still having the bad habit of eating high carbohydrates, this means that he will suffer definitely from hyperinsulinemia. Because once you eat the high carb meal, at the same time, once it's absorbed, your insulin will spike very high to compensate for this high level of glucose is coming in the blood. This is natural response by our pancreas to high carb meal or to elevated glucose in our body. Our body were created to deal with the spikes of glucose by this way. So a spike of insulin after the meal means once this meal with a spike, the next meal with a spike, the next meal with a spike. So a spike on a spike on a spike. This will cause a state of hyperinsulinemia. That's why explains some of the people, they would say, after I take the meal, I feel some brain fog. I feel some dizzy. I feel those feelings. They are actually some expression of hyperinsulinemia, because brain fog is highly associated with hyperinsulinemia. And some people would say that after taking the meal, I just feel quite lazy. I feel that I can miss information or forget some information. This is why actually hyperinsulinemia is highly associated with Alzheimer and dementia. So so that's the issue. We by nutritional therapy, it's a good point that we tackle the root. If we just use herbal, I mean, herbals are okay, but okay to use with something to break the vicious cycle, or something to break the cycle of hyperinsulinemia and insulin resistance, and with something tackling the root cause. At that point, yes, herbal medications will help. But if you just use herbal medication and the patient is still following the habit of eating high carb and spiking his insulin, then we are just using the herbal medication as a cosmetics. It can help a little bit, but after some time, it won't be helpful. And you can just see that with some patients. You can see some patients, they will tell you, I use this herbal drug and it was very effective, but after sometimes it's no longer effective. I want to highlight something here, that when we talk about herbal medication, I'm talking a pure herbal medication that you get them from a trusted source, because unfortunately some herbal medications are actually mixed with some sulfonylureas or other drugs, and this is unfortunately is spread globally and it's happening in many countries. So I hope that answers you. So is there any other questions?
Hello, Dr. Arwa.
Yes. Yes.
Thank you. Thank you.
I'm Valeria. I have a question. Here, they're low carb. They replace the carbohydrates with consume quinoa. My question is it okay to consume quinoa on a low carb diet? Is quinoa can cause a rapid spike on blood sugar? Because I read on Google that quinoa, it's not a low carb food, because a cup of cooked quinoa has more than 39 grams of carbohydrates.
Okay, thank you for your most welcome. My pleasure. Thank you for your question. No, actually, quinoa is not a low carb food, and quinoa contains high amount of carbohydrates and it high glycemic load, so it will cause a spike of blood glucose and spike of blood insulin. So it's not a low carb food. And this brings me to one more information that people always ask, okay, what I can use instead of bread, because I'm using quinoa to make bread and I want something to substitute bread. You just can Google for low carb bread, and they in low carb they use coconut flour, they can use linseed flour, they can use sesame flour to make bread or desserts or any other recipes. But quinoa is totally not a low carb.
Thank you, Doc.
Ramita sama Adeliana boleh bertanya. Kinta silakan. Yang ada di sini dipanggil saja namanya.
Ramita.
Ramita.
Mungkin disebutkan saja pertanyaannya, Kinta.
Okay, next third question from Ramita.
Kinta, mungkin bacakan saja yang pertanyaan si Kinta tadi.
Question from Ramita. What do you think about Health Science Authority 8SA Singapore as Food and Drug Administration FDA update and press announcement on NDMA in metformin and metformin get recall?
I mean, the formulation of metformin, do you mean that some formulations of metformin regarding its association with certain types of cancer? That's your question?
Yes.
Yeah, well, actually, this is related to certain special or certain types of formulations. I mean, we have several formulations of metformin. So this formulation only should be avoided, but you can find a good formulation that does not contain these substances, which is associated with cancer. And also I would like to highlight that many countries actually stopped importing or approving such type of formulations. I mean, for at least I'm talking here in Saudi Arabia, for example, the formulations of metformins are all safe in terms of this concern regarding cancer. So I think also in Malaysia and East Asian countries and also in Indonesia, I think they will follow such kind of rules, but I'm not sure because I'm not following the rules in your country.
Okay, thank you, Dr. Arwa. And the next question from Adeliana. Adele? Okay, I will read question from Adele. Patient T2DM with 8HbA1c more than 9%. Can we give insulin basal for first-line therapy? And medical record, patient never get therapy diabetes.
If I got your question correctly, you are saying that if there is a patient with an HbA1c is more than 9%, what is the treatment for that patient? Or you are talking about, can we give insulin? In fact, based on the guidelines, if the HbA1c is more than 9, we should give the patient insulin. But if I'm talking about type 2 diabetes patient, but in that state, the patient should also take metformin with insulin, and also they should follow nutritional therapy with insulin, and we start with basal insulin, and then if it was not effective in achieving glycemia, we use multiple dosing insulin injection, where the patient use basal insulin as a long acting, and then use rapid insulin for meals. I hope that helps. So any more questions?
I think Rianti Sembiring, you can ask directly to Dr. Arwa. So she has 3 questions here. Arianti? Arianti, buka mute-nya. Coba di-unmute. Ya.
Yes, Miss. Good afternoon, greetings and greeting healthy to Dr. Arwa. I am Arianti Sembiring, University student, 17 August, Jakarta. I would like to ask the first, on the slide, there is a type of war food. What does it mean? And the second, in this day and age, I think that people with diabetes do not know the age where at a young age there are already sufferers I want to ask what factors are the most dominant so that young people suffer from diabetes. And the third, according to the doctor, uh, which is more dangerous with type 1 diabetes or type 2 diabetes? Thank you, doctor.
Sorry, I would like you to clarify for me the first question.
The first question is the type. What is the meaning of the war food? Maybe you mentioned in your slide war food.
War food?
Yeah.
Yes.
Raw food?
War food.
Raw food. Raw food. Meaning is raw food. I think they said here war food. They say the right here is war food. War, like a war.
Yeah, I also surprised. I did not.
Maybe raw food. I think maybe raw food. Maybe the mistake.
Yeah, raw food means raw food. It's as natural from God. It's
yes.
not processed. I mean, you can get, for example, the meat and you just cook it at home. But some meat you can get it canned or something. This is processed food. But raw means as it is, without any processing.
Yeah.
So this is the first question. So the
The second question that she asked about why a lot of people, young people now get diabetic. What is the most risk factors for that? Usually we know that after 50 they got diabetic, right? But right now, just 20, 25, 30, they already got diabetics. So she wants to know what are the most factor for that.
So it depends which type of diabetes you are talking about. If you are talking about type 2 diabetes in children now, it's increasing a lot. And some children with 6 years old are getting type 2 diabetes. And the reason is because of the poor habits and lifestyle, unhealthy lifestyle, and high hyperinsulinemia. And there are also other reasons, like if the mother, for example, she got gestational diabetes. Some studies showed that the infants will develop type 2 diabetes later in their life because they started hyperinsulinemia while they were fetus in their inside their mother's body. If you're talking about type 1 diabetes, type 1 diabetes is an immune disease, and where the body, the autoantibodies from the body will attack beta cells. So there are many reasons for that reaction, and some are relating it for the increase of pollution or pollution in food or other things that will cause the immune system to attack itself, attack the beta cells of the body. So the third question is what? I missed, I forgot.
Which one more dangerous? Diabetic type 1 or diabetic type 2?
Okay. Which is more dangerous and may have a lot of complications is type 2, not type 1. Type 1, if controlled well and the patient adjusted their insulin doses based on food and based on carbohydrates content of the food, and they know how to dose their insulin, because patients should know how to dose their meal insulin and daily insulin, they will not suffer complications. I mean, for type 1. But for type 2, the issue, as I explained in my lecture, the patient get diagnosed with type 2 diabetes after a long journey of complications from insulin resistance and hyperinsulinemia. So they may actually face the complications before being diagnosed with type 2 diabetes. So it's much more dangerous in that term.
Okay, thank you, doctor.
Most welcome.
Okay, I think no more questions, right? Ainun?
Right.
Okay.
If there is no any question, I would like thanks to Dr. Arwa. The information and knowledge which have been given to us, it may useful for us. Thanks to the audience that had participated actively. For the next session, I return to the MC.
Thanks to moderator. Before closing, we have something we have something for you, Dr. Arwah. It is certificate of appreciation. Operator, please share certificate.
Thank you.
Operator, please share certificate.
Thank you.
Okay. Okay, to audience, please open a video. And let's take a picture together. Is it done? Is it done, operator?
Tahu nak.
Sudah. Oke.
Kinta, suaranya nggak kedengaran, Kinta.
Sorry. Yeah, finally we got the last session in this event that it's closing. Thanks to Mrs. Dr. Arwah Muhammad Amin Mustafa for the information and knowledge which having given to us. May it be useful for us. Thanks to Mrs. Dr. Pharmacist Diana Lela Ramatila M.Pharm. Thanks to Mr. Dr. Pharmacist Sumantri and Mrs. Pharmacist Rabima S.Pharm. And thank you for the participants in this event. I will say goodbye. And close this event by saying Hamdalah. Alhamdulillah. Thanks for participating in this event. I will say goodbye. Apologize if there are any word mistakes. And good afternoon, everyone. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Kinta.